2. We are live. Yes.
A very good evening to everyone present. At the outset, I welcome you all for the Day 4 activities of the Penta Day program on the occasion of the World Kidney Day, being organized by the none other than the very spirited and the very dynamic group of Women in Nephrology India. We all know that tomorrow, 14th March, will be celebrated globally as the World Kidney Day. The theme this year is Kidney Health for All, Advancing Equitable Access to Care and Optimal Medication Practices. At the outset, let us revise some facts. We know that among 10 people, 1 in 10 people in the globally are affected with kidney diseases. Not only that, in 2019, more than 3 million people deaths were attributed to kidney diseases, making it as the 7th highest risk factor of death worldwide. Not only that, our studies have shown that there is a significant gap between what we know and what we practice. Like in the Cure CKD registry, it has been shown that only 40% to 60% of the patients who were hypertensive or diabetics are aware of the diagnosis. And also, only 5% of the patients of CKD who are eligible of SGLT2 inhibitors are actually receiving it. So, with the objective to close this gap between what we know and what we practice, we start today's program. We'll start with state-wise chapter, initiating with WIN Andhra Pradesh group, where we'll discuss the methods to prevent the kidney diseases. Then we'll go on to the WIN Karnataka group, where we'll discuss the various barriers to achieve this equitable access to care for all. Then we'll go to WIN Telangana group, where we'll discuss the optimal kidney care services in the organized public sector hospital. And lastly, we'll have a panel discussion with the eminent nephrologists of WIN Kerala, WIN Tamil Nadu, WIN East Zone, and WIN Central Zones on how to achieve this optimal kidney care services. So at the first, I would like to invite the chairpersons for the first session, that is by the WIN Andhra Pradesh group, which is prevention of kidney diseases. I would like to invite the eminent nephrologist, Dr. Jikki Madam, retired additional DME and retired principal of Kurnool Medical College, professor and HOD of Kurnool Medical College, KMC, Kurnool, Andhra Pradesh. I would like to invite Dr. Amanna, Director of Arun Kidney Center, Vijay Kumar, Professor and Head, Department of Nephrology, Narayana Medical College, Nellore, India, to kindly introduce the speaker and initiate the program. Dr. Jikki Madam, Dr. Amanna, over to you, Madam.
Yeah. Good evening.
Good evening.
Yeah, please go ahead. Who is Dr. Bharati is presenting, no?
Yes, sir. Good evening, sir.
Good evening. Can you introduce yourself?
Sir, I am Dr. Bharati, sir, nephrologist working in Vijayawada, sir. I did my MD from Tirupati Medical College, Tirupati, MD DM from Nizam Institute of Medical Sciences. After completing my DM in the NIMS, I have worked under Amanna, sir, for the past 5 years. Recently only I have shifted to our own hospital, but I have learned very vast experience working with Amanna, sir, which simultaneously I have learned with what I have learned in the NIMS. I was always grateful for you, sir.
No. We are very happy. Today the topic is very important topic, preventive nephrology, which you are going to speak about it. And since we are seeing last 30 years, I am practicing by recognizing the disease in early stages and using the preventive drugs like ARBs and salt and protein restriction. My video is lost, I think.
Sir, you can continue. Sir.
Hello.
Yes, sir.
Yeah.
You are audible, sir. You can continue, please.
Yeah. By practicing like preventive nephrology for the past 30 years, we could prolong the patients on conservative management before going them for the dialysis. Like I have a patients right from almost 10, 15 years, their creatinine will be 2, 3. Just because we give them, we ask them to restrict the salt and we give them early ARBs and we treat the proper hypertension control. And these are all very important for us because the incidence and the prevalence is day by day, it is going up and going up. Maybe now I think our Dr. Bharati will enlighten us further into it. Bharati, go ahead, please.
Thank you, sir. Today I'm going to talk on prevention of kidney diseases. So why should we prevent kidney diseases? Because the chronic kidney diseases are major public health concern worldwide, and there is also an upward spiral in both the incidence and prevalence of kidney disease. And recent data showed that this chronic kidney disease was previously the 13th on the list of cause of death on the worldwide scale. And by 2040, it is anticipated to be the 5th leading cause of years of life lost. And in 2010, data showed that 2.6 million individuals were receiving some form of kidney replacement therapy worldwide, but an almost equal number had died during the same year because of lack of access to dialysis and transplantation. This scenario is alarming because when we see the data compared to with the other major chronic diseases like cardiovascular diseases and respiratory diseases, where the mortality with these diseases is declining, but the mortality with chronic disease is increasing. And according to the Global Burden of Disease 2017, there were approximately 649 million cases of CKD worldwide, of which 115.1 million cases live in India. And according to various contemporary studies, the CKD prevalence in India occurs to 8.7 to 16.4%. And disproportionately, these kidney diseases affect the disadvantaged population, which reduce the number of productive years of life. So this financial burden demoralizes many patients from undergoing the treatment, which leads to the preventable morbidity and death. So because of this morbidity and mortality that CKD is causing, definitely there should be preventive measures to decrease the burden of chronic kidney diseases. So coming to the preventive strategies for the chronic kidney diseases. In 2020, the World Kidney Day campaign highlights the importance of preventive measures, whether be it primary, secondary, or tertiary. The theme of that World Kidney Day campaign was kidney health for everyone, everywhere, from prevention to detection and equitable access to care. So we all know that there are 3 types of prevention, that is primary prevention, secondary prevention, tertiary prevention. In primary prevention, these are the interventions that we do before the onset of, that is, we apply to prevent the onset of illness or the injury. And secondary prevention suggests preventive measures that we follow for the early diagnosis and prompt treatment of the disease. Whereas in tertiary prevention, already the disease is very well established, and here we follow the measures to control the disease progression and the emergence of more severe complications. And we all know that health and diseases are a part of continuous process. The history of CKD, the progression or the history of CKD offers various preventive strategies at different timeline of CKD. This is an illustration which shows the timeline of kidney disease and the various modalities of prevention, that is primary prevention, secondary prevention, and tertiary prevention, which can be employed so that the chronic kidney disease can be identified early and disease progression can be halted. We all know the stages of chronic kidney diseases, like it starts with renal hyperfiltration, emergent or worsening albuminuria, declining GFR, and worsening uremia. The primary CKD prevention, it focuses on the risk factors, that is before the onset of the kidney disease. So we identify the patients who are more prone for the kidney disease, like risk factors like diabetes, hypertension, obesity, polycystic kidney disease, solitary kidneys, and people who are on high salt and high protein intake. All these people are more for developing of the chronic kidney disease. So at the primary level, we can mitigate these risk factors and we can advocate the people to control their BP, to control their sugar, and to manage their obesity, avoid the high salt diet, encourage the healthy food and lifestyle. Coming to the secondary disease, in the secondary disease, The main aim is to identify the disease at early stage, and after identifying the disease, giving the prompt treatment of the disease so that it doesn't progress. So the main goals in secondary prevention are slowing the CKD progression, delaying or the deferring the dialysis transition. So the methods usually implemented in this phase are early CKD detection by various screening programs, better BP control, use of advanced pharmacological therapies that delay the progression of the CKD, and advising on the CKD plant-based diet, avoiding the AKA events. And coming to the tertiary prevention, in this stage, already the patient is having advanced CKD. And the main aim of tertiary prevention is to manage the uremic symptoms and comorbidities and to improve the quality of life of the patient. And in this phase, we have to control the uremia and fluid management, and we have to give tailored cardiovascular and nutritional therapy, pharmacotherapy to the patients by means of conservative management. And in advanced chronic kidney disease, we should also explain the patient about the renal replacement therapies available, and all the palliative care and supportive care should be provided in the tertiary prevention. So this diagram, this illustration clearly explains the timeline of CKD and the various interventions, primary, secondary, tertiary interventions that can be implemented to prevent the kidney diseases. So coming to the primary prevention, that is risk factors for de novo chronic kidney disease or the pre-existing CKD progression. So diabetes, as all we know, diabetes mellitus is the 50% cause of chronic kidney diseases, followed by hypertension, which contribute to 25%, obesity 10 to 20%, and chronic kidney disease also seen in advancing age, especially in the setting of comorbid condition. And chronic kidney disease is common among those with African American ancestors. And the rest causes like hereditary factors, acute glomerulonephritis, polycystic kidney diseases, acute kidney injury, autoimmune disorders like SLE, and medications causing interstitial nephritis like NSAID, CNI, chemotherapy, herbs and herbal medication, environmental exposure, heavy metal exposure. All these contribute to the less than 10% as the cause of chronic kidney disease. So now the concept is evolving, the programming of kidneys during the in utero. So healthy mother, healthy child. So if the mother is healthy, the child develops in utero healthy, there will be programming of kidneys will be healthy. So even after the delivery or during the adolescent phase or adult phase, these children are not exposed to the risk factors for chronic kidney disease. So this is the concept of programming of kidneys in the utero. Why it is important? Because globally, approximately 10% of the babies are born either preterm or short for gestational age or low birth weight. The main risk factors for these preterm birth, short for gestational age, etc. are preeclampsia, prior preterm delivery, advanced maternal age, chronic maternal illness, and infertility is becoming a major problem, leading to opting for assisted reproductive techniques. And in females with multiple gestations, preeclampsia is at high risk. So the link between developmental circumstances and the risk of chronic kidney disease is mediated by altered renal development in the utero or shortly after the birth, which is associated with a reduced nephron number, which leads to subsequent hyperfiltration during their development and predisposition to hypertension. And if this child grows in a stressful environment, there are also chances of developing the diabetes mellitus in the younger age, even though the mother and father are not diabetic. So we should take care of the mother, healthy mother. Mother should be taken care of so that the child is healthy, and future this child will not develop the chronic kidney diseases. So healthy mothers begin with the healthy girls who receive good nutrition during their childhood, grow up in the safe environments with adequate resources, and they are well educated, and they have access to equitable access in the society. So coming to the primary preventive strategies for chronic kidney disease, there is no CKD specific primary prevention program, because the causes for the chronic kidney diseases are most of the risk factors for the non-communicable diseases like obesity, hypertension, and diabetes. So the measures which mitigate these risk factors like obesity, hypertension, and diabetes are likely to benefit the people without developing the chronic kidney disease. The main aim is to promote the health, provide the health education, and advise the people to follow the healthy lifestyles like avoid alcohol products, be physically active, cut down on salt and sugars, do not use the tobacco products, eat plenty of vegetables and fruits. So these are the various illustrations or the World Kidney Day themes that highlight the importance of public health strategies and advocacy for the prevention of chronic kidney diseases, like start early, optimize the women's and child health, and act early to prevent AKI, be vigilant on AKIs, protect your kidneys and save heart, protect your kidneys, control the diabetes, start the day with a glass of water. These are all the various posters that were released on the World Kidney Days to highlight the importance of public health strategies. So that is about the primary prevention. Coming to the secondary prevention. Secondary prevention includes early detection of the disease in those people with risk factors for chronic kidney disease and prompt treatment of the disease. So who should be screened for chronic kidney disease? Whether we should screen the general population or we should screen only definite group of population for identifying the chronic kidney disease. Usually, screening the general population is not cost effective because lot of resources are needed both manually and technically to screen the large number of population. And even if these population are screened, if the chronic kidney disease is identified in these people, this leads to alarm in the panic condition in the patients. And even if these are diagnosed, our infrastructures in the low middle income countries are not sufficient to handle all these patients at a time. So majority of the groups like various international and national organization, whether it is US Preventive Services Task Force, American College of Physicians Task Force, NICE UK guidelines, American Society of Nephrology, National Kidney Foundation, Kidney Disease Outcomes Quality Initiatives, KDIGO guidelines, Canadian Society of Nephrology. These are all the various organizations that screen the population for kidney disease. None of the organizations recommend for the general screening of the population for the identification of chronic kidney disease. All these organizations recommend that only the patients with risk factors for chronic kidney diseases, like those patients who have long-standing hypertension, long-standing diabetes, and patients with family history of kidney diseases, obesity, these should be screened for the incidence or prevalence of chronic kidney disease. So what are the various tools available for the screening of kidney disease? Chronic kidney disease can be diagnosed and staged based on the glomerular filtration rate and level of albuminuria. GFR can be easily estimated by the CKD EPI formula using age, sex, ethnicity, and serum creatinine level. And the level of albuminuria can be assessed by either 24-hour urine albumin excretion or by spot albumin creatinine ratio. So we know now whom we should screen and what are the methods we can use for screening. Then the question comes, who should perform these screening methods? It is always a question, especially when the healthcare professionals availability is a challenge in lower income countries. Physicians, nurses, paramedical staff, and other trained healthcare professionals are eligible to do the screening test. It is important not only to identify the chronic kidney disease. Those people who are identified with the chronic kidney disease, they should also be offered the treatment. That is, interventions also must be done after screening. And patients should be timely referred to the primary care and general physicians with experience in the management of kidney disease for follow-up. And there should be a management protocol should be provided for the primary care and general physician. And further referral to the nephrologist for the management should be based on well-defined protocols. So what are the barriers to greater uptake of secondary preventive activities at the primary care level? So now we have talked about whom should we screen and what are the screening tools and who should screen. But this is not that much easy to be implemented in our low middle income countries because there is lack of awareness of the disease by the healthcare providers in the community. and there is lack of CKD specific prevention or the management education opportunity for the healthcare providers, and there is lack of adequate workforce such as that because healthcare providers are involved in the multitasking, and failure to retain the trained healthcare professions because they are lost to the private sector or they have moved to the other areas despite being trained and being highly knowledgeable in the specific areas. And on the part of the patient also, there is lack of focus on the wellness or self-management support. So these are the various types of barriers to implement these secondary preventive measures. So how can we overcome these barriers? We can overcome these barriers because there are close links between the chronic kidney disease and other non-communicable diseases. It is critical that CKD advocacy efforts to be aligned with existing initiative concerned with NCD, particularly in the low middle income countries. That is, integration of CKD prevention into the national NCD programs. Because the manpower and what are the technology we are using to identify the non-communicable diseases, simultaneously we can identify the risk factors are same for both for the chronic kidney disease. We can sample these patients and identify the chronic kidney disease at the earliest. So many countries have integrated their CKD prevention into the national NCD programs. One such country is Taiwan. In 2003, a kidney health promotion program was introduced in Taiwan with its key components, including ban on the herbs containing the aristolochic acid, public awareness campaigns, patient education, funding for the CKD research, and setting up of teams to provide the integrated care. And this integration of CKD prevention into the NCD program has reduced the renal and cardiovascular risk in the general population. The main outcomes have been the reduction in the prevalence of the risk factors such as low birth weight, smoking, and infectious diseases. There has been increased rate of diagnosis of diabetes and glycemic control, well increased in diagnosis of patients with higher hypertension, higher prescription use of renoprotective treatment with ACE inhibitors, and higher rates of blood pressure control. And another such program is US Department of Health and Human Services. It has introduced an ambitious program to reduce the number of Americans developing ESRD by 25% by 2030. This program is known as Advancing American Kidney Health Initiative, and it has set goals with metrics to measure its success with an increased efforts to prevent, detect, and slow the progression of kidney disease, in part by addressing the traditional risk factors like diabetes and hypertension. Since its implementation, the incidence of diabetes-related kidney failure among the Native Americans has decreased by over 40% between 2000 and 2015. So like this, we can integrate the NCD programs into the CKD awareness programs also. And the next step to overcome the barrier is providing the medical education on the chronic kidney disease. So there is shortage of nephrologists even in the developed countries and developing countries. According to the data, there is less than 10 per million population of nephrologists in the developed and developing countries. So this nephrologists cannot handle the chronic kidney disease patients. So the medical education on chronic kidney disease should be provided to the primary healthcare physician, general physician, to promote awareness on the CKD, what are the risk factors for CKD, how can we prevent the CKD, and when to refer the patients for the nephrology. The e-learning has become an increasing popular approach to give the education. One such online program was implemented in Mexico. By 2015, many health professionals has been trained on electronic health education platform. And a novel strategy has been successful ISN fellowship program. Since its implementation in 1985, over 600 fellows from more than 83 low middle income countries have been trained. And we can also use the internet. A lot of information is available on the chronic kidney disease, whether related to the risk factors, preventive measures, treatment opportunities. And we can use this information to train our patients or population. And there are also mobile apps which are available, which provide the chronic kidney disease education to the patients. So all these medical education can be used to prevent to create the awareness among the population and prevent the chronic kidney disease. So these are the selected websites with information on the chronic kidney disease patient education. So in the secondary prevention, already we thought that the main goal is to identify the disease at early stage and also prompt treatment of the kidney disease. So we have identified the kidney disease through various screening methods, and now we have to go for the treatment. We should advise the patients on lifestyle modification. We should maintain the BMI less than 25 kg per meter square. We should advocate on low salt intake, smoking cessation, 30 to 60 minutes of exercise, 4 to 7 days per week. And proteinuria, albumin should be treated with AC inhibitors or ARBs. And blood pressure goals in proteinuric CKD should be less than 130 by 80 millimeters of mercury, less than 140 by 80 millimeters of mercury in non-proteinuric CKD. And HbA1c should be targeted less than 7%. And use of statin should be advocated who are more than 50 years of age. And to prevent the cardiovascular morbidity, use of aspirin, beta blockers must be advocated for patients who have established cardiovascular disease. And there are various studies and drugs that showed the delayed progression of chronic kidney diseases in diabetic nephropathy like ACE inhibitors and ARBs, SGL2 inhibitors, fluozins, finerenone. In case of polycystic disease, like uses of Vaptons also slowed the progression of polycystic kidney disease, and prescription of aspirin to women who are at a high risk of preeclampsia also decreased the incidence of preeclampsia and simultaneously low birth weight and the prevention of chronic kidney disease. So these pharmacological measures also should be taken and should be implemented to prevent the progression or to delay the progression of disease. So coming to the tertiary prevention in chronic kidney disease. In tertiary prevention, the disease is already established in the patient. And most nephrologists, we see these, we are involved in this tertiary prevention of CKD because, and the main aim is to manage the uremia and its complications like anemia, mineral and bone disorders, and to prevent the cardiovascular morbidity. And the main aim is to achieve the highest longevity in the patient. And depending on the CKD stage, we should motivate the patient for creating the early access. And we have to explain the patient about all the modalities of renal replacement therapy, whether it is hemodialysis, peritoneal dialysis, transplantation, and transplantation, the options of the live donor transplantation and cadaver deceased donor transplantation. So
we are short of time.
Okay, sir. Completing, sir. 2 minutes. So this is one illustration, the spectrum of strategies of chronic kidney disease prevention across the life course, that is from fetus to the elderly. The preventable and treatable risk factors for CKD in fetus or neonates, low birth weight, preterm, short for gestational age, maternal diabetes, maternal overweight, preeclampsia, neonatal AKI. In child, it is increased incidence of BP, increased BMI, and in adolescent, usage of nephrotoxin, smoking, and trauma, preeclampsia, and early pregnancy or late pregnancy. Whereas in adults, the risk factors are smoking, pregnancy, occupation exposure, nephrotoxin, in addition to the traditional risk factors. In elderly, it is aging, comorbidity, nephrotoxins, and AKI. All these risk factors can be identified early, and we can use the pharmacological therapies to prevent the progression of kidney diseases. So finally, World Kidney Day 2020 Steering Committee suggests the following goals to redirect the focus on plans and action. That is, empowerment through the health literacy in order to develop and support the national campaigns that bring the public awareness to prevent kidney disease, and population-based approaches to manage the key known risk factors for kidney diseases, and implementation of WHO best buys approach, that is screening only at risk of population for CKD, providing universal access to early essential diagnostics for early CKD identification, availability of affordable basic technologies and essential medicines, and task shifting from doctors to frontline healthcare workers to more effectively target the progression of CKD. So thank you. We all know that an ounce of prevention is far better than a pound of cure. Thank you.
Thank you, Dr. Bharati, for a very good presentation. You have enumerated all the three causes, three measures, and we can open the topic for the discussion.
I would like to say a few words. congratulate you first of all for a very good presentation, Dr. Bharati.
Thank
But I
you,
would
ma'am.
like to also say that the government of AP is introducing a new pilot project for the prevention of kidney diseases from tomorrow onwards. It's an integrated artificial intelligence to the clinical medicine to be launched tomorrow by government of AP. As a pilot project, 2,000 at-risk patients will be screened at the level of PHC by primary care physician. And this is a pilot project, and I'm sure that this will go on to become a major project in the state as well as the rest of the India, most probably.
Yes, ma'am. Various programs are also being organized, madam, like PM Modi scheme for providing dialysis facility throughout the
Yeah, that's all the tertiary care. We are talking about the primary prevention care, where this program will be of great help because you are integrating artificial intelligence to the clinical medicine for the
primary prevention.
Primary care. The pilot
ma'am.
project will be at the level of PHCs, primary healthcare centers. And this would be at the grassroots level, so that we'll be able to catch the patients at a very early at-risk patients and give them adequate care. So this is actually our theme of this World Kidney Day, that we will be extending this access to equity care in kidney care.
Yes, ma'am.
Ma'am, I have the video of Dr. Maitri.
No, just hold on, Shyam. I mean,
Dr.
Praveen, if you can
Praveen has-
just make a quick comment and then we end the
Yes,
Andhra
Dr.
Pradesh
Praveen,
section. Dr. Praveen, yes, please.
Yeah, excellent talk, Dr. Bharati. You have rightly brought up the preventive strategies, especially in a country, developing countries like India. We cannot afford even tertiary prevention. Only you have to mainly focus on the primary and secondary prevention. And other thing you have brought up is the nephron endowment, where IUGR and low birth weight kids can develop hypertension and CKD in the later stages when they don't take proper precautions. So mainly the protein restriction and they have to take care of their health, and frequent checkups are needed. So it was overall a nice talk on preventive strategies, which we have to focus. And I don't say there's a death of nephrologists in India. There is already saturation of nephrologists. So only thing, the new generation has to choose the right field. Some of them have to go for preventive nephrology. So some nephrologists can, some of the students, the new generation nephrologists can go for preventive and then interventions. You have to choose the different fields. So not that everybody should focus on the dialysis and transplant. So that's what I feel, that the nephrology number is sufficient, and we have large number of postgraduate seats all over India. And I think we as a nephrologist can take care of the entire kidney patients. That's what I feel. Thank you once again for giving me this opportunity.
Yeah, thank you, sir. It was a wonderful lecture from the WIN Andhra Pradesh team. And as sir and madam emphasized that prevention is always better than cure, and it is the preventive nephrology that all the young nephrologists should focus on. So in the need of time, we would like to take all the questions at the end of the seminar. We would now progress to the WIN Karnataka chapter, where we will discuss the kidney health for all, barriers to equitable access to care, and optimal medication practices. I would like to invite the chairpersons for this talk. I would like to invite Dr. Renuka, Professor and ex-head of the department, St. John's Medical College, President, WIN India Karnataka chapter, and Dr. Swarna, consultant nephrologist and renal transplant physician, Abheksha Hospital, Bangalore, to kindly chair this session and start with the proceedings. Thank you. Dr. Renuka, ma'am, kindly unmute yourself, ma'am. Madam, kindly unmute yourself. Madam, kindly unmute, ma'am. In the end, there will be a mute button. Kindly unmute yourself, ma'am. No, madam.
Ma'am, do it once again, ma'am. You just unmute.
Madam, at the end of the screen, in the lower end, there will be a mute button. I think we can proceed with Dr. Swarna, and in between we'll come to Dr. Renuka. Dr. Swarna, I request you. Yes, ma'am. Dr. Renuka, ma'am, we can hear. You can please introduce Dr. Mithri, the session, the speaker of the session. Hello.
Ma'am, we are unable to hear you, ma'am.
Yeah.
No worries, Kajri. I think Dr.
Sham,
Swarna
please
Shashi
check on
Bhaskara, can you just please introduce the
Yeah,
speaker?
Dr.
And
Swarna.
then meanwhile,
Yeah.
Sham, can you just help Dr. Renuka to unmute and then participate in the further proceedings? So over to Dr. Swarna to introduce the speaker.
Good evening, all. Thank you so much for giving me this opportunity. I wouldn't waste time by using several words. I know Dr. Maitri Shankar personally, one as a colleague, and I know her as a assistant professor from Institute of Nephrology, a passionate teacher, an excellent clinician. And I also know her as a GlomCon instructor because I am doing GlomCon myself, and she is my instructor. In addition, she wears multiple hats. I think I don't have enough time to tell all those. I think it's too much which she does. And I always wonder, and I personally questioned her, how do you do all this on your own, which I really mean it. So I would love to invite Dr. Maitri Shankar to to start the meeting, which is my passion to prevention and equitable access to healthcare to all, even including remote settings. Over to you, Dr. Maitri.
Sham, audio, Sham.
This year's World Kidney Day theme.
Yeah, it's audible.
The Kidney Day Steering Committee has declared 2024 the year of kidney health for all, advancing equitable access to care and optimal medication practice. The 2024 campaign will focus on raising awareness about the importance of ensuring equitable access to appropriate treatment and care for people living with kidney disease in order to improve their quality of life as well as delay the progression of the disease. If you look below here, you can see that the logo has been revamped. The above one is the newer logo and the below is the old logo. In the old logo, we can see three colors. Blue stands for water, yellow for urine, and red for blood. If you look at the new logo, there is a new color that has been added, which is the color green, which represents sustainability, a core value that has been embraced by the nephrology community around the globe. Let's look at some fascinating facts about kidney disease. Kidney disease is not uncommon. In fact, it is very common. 1 in 10 people worldwide are living with kidney disease. Global mortality from all kidney diseases may actually range between 5 and 11 million per year, especially in low-resource settings. Kidney disease is the 7th leading cause of death, and it is projected to be the 4th leading cause of death in the year 2040. Diabetes and hypertension are the most common risk factors. 1 in 3 people with diabetes have chronic kidney disease. 1 in 5 people with hypertension have chronic kidney disease. Unfortunately, 40% of those with hypertension and 60% of those with diabetes are unaware of the diagnosis. When we look at all the causes of chronic kidney disease put together, 80 to 93% of the patients were unaware of chronic kidney disease. It is obvious from these figures that chronic kidney disease is a silent disease and patients don't develop symptoms until the kidney disease is advanced. So why is it important for us to detect and treat chronic kidney disease early? Of course, it increases the morbidity and mortality rates if not detected early. At the same time, chronic kidney disease also poses a significant global economic burden. If you look at the cost of dialysis, it ranges between 24,000 to 48,000 Indian rupees per month. The cost of transplantation varies from rupees 5 lakh to rupees 15 lakhs, depending on whether you're getting the transplantation done in a government setup or a corporate setup. Patients with chronic kidney disease have multiple comorbidities such as diabetes, hypertension, and associated complications such as anemia, mineral bone disease, acidosis, and so on, which requires medication. The cost of these medications comes up to anywhere between 10,000 to 15,000 Indian rupees per month. Even the cost of post-transplant immunosuppressive drugs comes up to around 10,000 to 15,000 rupees per month. Added to this, we all know that patients with chronic kidney disease are immunosuppressed. They are prone for pulmonary edema, they are prone for infections, they are prone for fractures, and so on. Also, they are at higher cardiovascular risk. So that would mean a higher risk of hospitalization. So if there's any added hospitalization, that would again add to the burden of existing costs. Data from many low resource settings are absent, but most costs are paid out of the pocket. And this degree of cost or this degree of expense is stressful even for people from upper middle class. It is alarming to know that the cost is higher than the per capita GDP of India. Early diagnosis and prevention of chronic kidney disease could save our Indian health system 850 billion Indian rupees over a span of 20 years. The core aspects in preventing chronic kidney diseases is maintaining a healthy lifestyle. Avoid smoking, limiting alcohol intake, and an active lifestyle, minimum of 30 minutes of exercise per day for 5 days in a week. Prevention and control of risk factors, diabetes, hypertension, and obesity. Keep the blood sugars, blood pressure, BMI under control. Optimization of maternal and child health. Postpartum sepsis and preeclampsia are the most common causes of obstructive acute kidney injury in India. Postpartum sepsis can be easily prevented by following safe surgical practices. Appropriate antenatal care with monitoring of blood pressure, kidney functions, urine routine is important to detect and treat preeclampsia. Addressing social and structural determinants of health, such as poverty, unemployment, racial discrimination, discrimination based on caste, creed, and sex, can also limit the accessibility of patients to healthcare services. Mitigation of climate change. Over the last decade, there have been many case series of CKD-U. U stands for unknown etiology from hot regions of India, such as Telangana, Andhra Pradesh, parts of Tamil Nadu, and Orissa. It is most commonly among the farmers who work hard under the sun with limited fluid intake, leading to repeated episodes of acute kidney injury due to dehydration, ultimately progressing to chronic kidney disease. Keeping oneself hydrated and drinking approximately 2 to 3 liters of water per day is important to prevent kidney injury. Avoidance of acute kidney injury. Other common causes of acute kidney injury, infections. India is a tropical country and we are prone for tropical infections such as acute gastroenteritis during summer months, leptospirosis, scrub typhus, malaria, dengue. If not detected early and treated, they may progress to multi-organ dysfunction syndrome, causing acute kidney injury, even leading up to kidney failure and requirement of kidney replacement therapy. Avoidance of usage of alternate forms of medications, which might be high in adulterated heavy metals such as mercury, arsenic, strontium, cadmium, and so on, and avoidance of abuse of painkillers, especially NSAIDs. People are dying because of missed opportunities to detect chronic kidney disease early and to deliver optimum care. So early diagnosis and treatment becomes very important here. Hence, time becomes very important here. We cannot afford to lose time. Strategies to prevent and treat chronic kidney disease have been built on a strong evidence base over the past 3 decades. Clinical practice guidelines for chronic kidney disease are very clear. They are freely available on the KidneyGo website. They are easy to follow. So the guidelines are easily available, evidence-based, and easy to follow. But why are we still having millions of deaths because of chronic kidney disease? The key question here is, are these guidelines being implemented? Implementation is the key factor here. If you look at the real-world data from electronic health records, you can see that there is a huge gap between knowledge and implementation in kidney care. If you look here at proteinuria monitoring in patients who are aware of chronic kidney disease diagnosis, is only 50%. Hardly 35% have their blood pressure under control, and hardly 60% have their HbA1c under control. RAS inhibitors were proven to retard the progression of chronic kidney disease 15 years back. But look at their usage now, hardly 35%. SGLT2 inhibitors were recently approved to retard the progression of chronic kidney disease. They work like wonder. They are wonder drugs. They are also called as flauzins. You would be surprised to know, for every 1,000 patients treated with SGLT2 inhibitors, we can avoid 83 deaths, 19 heart failures, 51 dialysis initiations, 39 episodes of acute kidney injury. But if you look at their usage, it is dismal, less than 10%, hardly 5%. Expert lifestyle and dietary advice, hardly around 20%. SGLT2 inhibitors, RAS inhibitors are something like, for example, advising angioplasty and stenting for someone with acute MI. You just cannot get away by not advising them angioplasty. Similarly, you just can't get away without prescribing SGLT2 inhibitors with anybody with diabetic nephropathy or other types of chronic kidney disease. So you have seen from RAS inhibitors that it takes approximately 17 to 20 years for new treatments to move from research to clinical practice. With millions of people dying with chronic kidney disease each year, don't you think 17 years is far too long for all of us to wait? We have to act now to bridge this implementation gap. The implementation gap is huge. In the era of internet, where we have the world on our fingertips, 17 years is way too long for all of us to wait. What are the reasons for this huge gap in implementation and continuity of care? First and foremost, it is the cost. Many of the patients may find the medications expensive. Even if it is generic medicine, it may not be easily available. So accessibility and affordability are the issues here. Second is lack of patient education. Some of the patients may just stop taking medications on their own, thinking that they are feeling fine. Mind you, chronic kidney disease is a silent disease. Educating patients about the importance of continuing medications and regular follow-up is very important. Polypharmacy. Patients may get confused due to the huge list of medications and they may just stop taking the medications. Also, fear of adverse effects may compel the patients to stop medications on their own without consulting their physicians. In low and middle income countries, the gap between evidence and implementation is even wider, given the higher cost and inconsistent availability of these medications. Such gaps in delivering optimal treatment for patients with chronic kidney disease are simply not acceptable. So we have to bridge the gap. And how do we do it? Let's look at our health policies and health systems first. Kidney health has not been prioritized in our health policies. It's usually cardiovascular diseases and malignancy that is given more significance. It is a good thing, but at the same time, the impact of kidney disease is equally huge. We need strong advocacy to prioritize kidney health in our health policies. CKD is only incorporated into non-communicable disease strategies in approximately 50% of the countries. Policies are required to integrate kidney care within the essential health packages under the universal health coverage scheme such as the Ayushman Bharat. Not just that, the health system must be strengthened and quality of care must be prioritized, as poor quality of care again contributes to more deaths than lack of access alone in low disease settings. Here is a list of medications that are essential for patients with chronic kidney disease. Across 18 countries, 4 cardiovascular disease medications, statins, ACE inhibitors, aspirin, and beta blockers, all often indicated in chronic kidney disease, were found to be more available in private settings than in public settings, mostly unavailable in the rural areas, unaffordable for 25% of the people in upper middle income countries, and 60% in the low income countries. So, steps must be taken to provide these medications at national levels under the Universal Health Coverage Scheme. Also, strict directions must be given to the pharma companies to provide these essential medications at affordable prices. include essential medications and basic diagnostic tests such as kidney function test and urine routine in the universal health coverage scheme. The quality of generic medications, especially in LMICs, is an additional barrier. Regulation and monitoring of drug manufacturing and quality standards are also important. In the early stages, CKD is asymptomatic. Targeted early screening of those at high risk, that is people with diabetes, hypertension, cardiovascular disease, family history, and obesity, is very important and offers the potential to significantly reduce the morbidity and mortality from chronic kidney disease and also its complications. Unfortunately, only 25% of the countries have CKD detection programs based on national policies or guidelines. Our states and country should include screening for kidney health in their health policies and guidelines. Recognizing potential symptoms are also equally important. Screening is done by measuring blood pressure, serum creatinine, urine analysis, and urine albumin or protein to creatinine ratio. This entire exercise hardly costs anything, maybe not more than 100 rupees. Early detection of chronic kidney disease will lower the costs over time by reducing the complications of chronic kidney disease and kidney failure, requirement of dialysis, requirement of kidney transplantation, and so on. Screening for kidney diseases, early identification of those with kidney disease, and treating them to prevent progression of chronic kidney disease is the best way forward for developing countries like India, where resources are limited. We cannot afford to use up our limited resources in establishing more and more fancy hemodialysis units. The cost of hemodialysis is only going to increase, and also we will have to deal with the perennial problem of water shortage. Looking at healthcare professionals, there is a shortage of primary care physicians, shortage of specialists, nephrologists, neurologists, cardiologists, especially in Tier 2 and Tier 3 cities. On top of this, we are pushing for brain drain by not paying them adequately. Reduce the time pressure, especially true in government hospital outpatient departments, where the number of patients to be attended are far more than the healthcare workforce can handle. This leads to excessive workload and clinician burnout. Improving clinician-patient ratio may overcome this barrier. Many knowledge gaps also exist regarding chronic kidney disease, especially among primary care clinicians. And such gaps are remediable with focused public and professional education. In some instances, we can also take the help of pharmacists, for example, to identify people with diabetes or hypertension and those at risk of chronic kidney disease based on the prescriptions that they bring to the pharmacy. They could offer testing on-site and they can refer the patients if needed. Mobilization of community health workers and Anganwadi workers may also facilitate in early detection, diagnosis, and management of chronic kidney disease. According to a study from Indian Express, the top 4 causes for the Great Resignation, the top 4 causes for brain drain were low salary, limited career and research opportunities, not being valued by leadership, and unhealthy relationship with colleagues. So it becomes a responsibility of the administration to look into each of these factors and improve working conditions of the healthcare professionals. Health literacy. Self-care is the most important aspect in kidney care. A patient should have the ability to understand his or her health needs, make healthy choices, feel safe and respected in the health system, and also have psychosocial support for important decision-making. The doctors should communicate clearly to the patient and the patient party regarding the condition of the patient, the importance of taking medications, the importance of follow-up, and also the cost of the medications, the cost of dialysis, the cost of transplantation, if at all it is required. To overcome barriers and to promote equity, patient perspectives are also essential to designing and testing better health strategies. So it is best to involve them in designing research and clinical trials. There are multiple methods to look at the patient perspective. We can do interviews, we can do focus group discussions, surveys, even simple conversation might be useful. The journey of each person living with chronic kidney disease is unique and their voices must be heard. Polypills are very attractive. These polypills are fixed doses of several guideline recommended medications that are presented in one tablet. It reduces the cost, it lessens the pill burden, and it is very simple to administer. These are the way forward. Using digital technologies, integrating telehealth and other types of remotely delivered care are important. to improve the efficiency and reduce costs. Electronic health records and registries can also support monitoring of quality of care and identify gaps to guide implementation and improve the outcomes. Artificial intelligence may also be harnessed to risk stratify and personalize medication prescribing and adherence. There are many apps that can remind the patients to take their medications. They can remind about the follow-up visits and so on. Telenephrology can be used for communication between primary care physicians and specialists. There are barriers for equitable access to care and optimal medication practice, but we can take steps to overcome these barriers. Comprehensive healthcare delivery, integrating kidney care into our existing healthcare policies, empowering our healthcare professionals, empowering our patients and patient advocacy groups may help in mitigating these barriers. Your support is vital. The support of general practitioners, general physicians, obstetricians, cardiologists, nephrologists is very vital. My only take-home message to all of you is that please check kidney function tests and do urine analysis to all the patients who walk into your OPD. Early detection and treatment helps a lot in retarding the progression of chronic kidney disease. Thank you so much.
Thank you, madam, for the wonderful talk. I would request Dr. Renuka, madam, to say a few words. Dr. Renuka, madam, you can kindly unmute yourself. You're not audible, madam. Dr. Swana, can you please take over?
Sure. I'm on a default mode now. Yeah, it was a very impressive presentation. I think few words from personal experience. I feel two deficits which I can see. One is essentially trust between the doctor and the patient, and the counseling, for whatever reason, it's coming down. So I think we need to integrate other team members into the group. Doctor might not be able to do everything. So the nursing staff, the pharmacist, the dietitian, if we speak the same language, it's easy for the patients to understand, number one. And number two is, I do say, how do we, I think this is a thought, it's things that we need to think about. It's as nephrologists, we are okay. Most of us on auto mode, we just write HbA1c, urine albumin creatinine ratio. But how do we educate the physicians in a political diplomatic mode so that they just don't do FBS, PPBS for last 15 years, then patient comes in after 15 years or so with creatinine of 4 when we have lost the boat. So how do we incorporate that? That's something which we need to think about. And third thing is, I think this hub and spoke model, which we spoke about earlier, is an amazing thing. As long as we have good working relationship, as long as we trust each other and we mutually respect each other, I think that's something which is way forward, is what I see.
Yeah, thank you, madam. We would like to take Dr. Renuka's words after the end of the session, because her audio problem. Okay, madam. Okay.
Kajari, Dr.
No
Maitri
issue.
is there.
Due to
If
the
she
short
can-
of time, we'll.
Kajari, Dr.
Oh,
Maitri
okay,
is
ma'am.
there. I
Yes.
think she joined.
Yeah.
If she can put in a quick comment, then we move on. We are behind the schedule by about 15 to 20 minutes. Maitri, if you're here online, you can make a quick comment and then we move on to the
I
next
would
thing.
like to
I
thank
think Dr. If is
Dr.
online,
Manju.
madam.
Can you hear me, ma'am?
Yeah, please,
Yes,
Maitri,
yes,
go
yes,
ahead.
ma'am.
Yeah. I would like to thank the Women in Nephrology India, especially Dr. Manjusha madam and Dr. Swarnalata madam, Dr. Urmila, Dr. Manisha Sahai ma'am, for taking all the efforts and organizing this Penta Day event. It takes a lot of energy to coordinate such a huge program. Event of 5 days is not easy. And you are all like our inspiration, and we all look forward to you. Thank you so much for arranging this for all of us, madam. Thank you so much.
Thank you, madam. Due to the short of time, we will now move on to the next chapter. So first we learned about prevention, how to prevent kidney diseases. Then we moved on to what are the barriers of equitable access for all. Now we will move forward to see the strategies for providing optimal kidney care at organized public sector hospitals in the state of Telangana, to be presented by the WIN Telangana chapter. I would like to invite the esteemed chairpersons, Dr. Anuradha Raman Madam, esteemed nephrologist, ex-head of the Department of Usmania Medical College, senior consultant nephrologist of Sunshine Hospitals, Dr. Gangadhar, Professor and Unit Head of Nizam Institute of Medical Sciences, Hyderabad, and Dr. Jyotsna, Senior Consultant and Renal Transplant Physician of Star Hospitals, Hyderabad, to kindly chair the session, introduce the speaker, and proceed with the session. Thank you.
Thank you, Kajati. Am I audible?
Yes, yes, madam.
Yeah. Thank you. After hearing about the preventive strategies for chronic kidney disease, we now come to more practical aspects of optimal kidney care services at an organized public sector hospital in the state of Telangana. Having worked in a public sector hospital for more than 35 years, I know the problems that we encounter and to what extent we should go to circumvent those in providing optimal kidney care to patients suffering from kidney disease. And to talk to us about how this has been done in a public sector hospital, we have with us Dr. Dhanalakshmi, who is a senior consultant nephrologist working in the ESI hospitals, which is a public sector hospital. And without wasting much time, let's see what Dr. Dhanalakshmi has to say about kidney care services at a public sector hospital, which is ESI hospital where she now works. Over to Dhanalakshmi.
Good evening, madam. Good evening to all the respected members who have in this meeting today. What madam said is absolutely true. Providing optimal medical kidney services at public sector or government hospital is a very challenging job. Today on this platform, I respect all the professors like Dr. Deshpande, Anuradha Madam, Girish Narayan sir, Dakshinamurthy sir, who has pioneered to provide the best of nephrology services in public sector hospitals, and which has been carried out by Dr. Manisha, Dr. Kiranmai Madam, Dr. Manjusha Madam, Dr. Shribhushan Raju, Dr. Gangadhar sir, and Dr. Swarnalata, and who have been relentlessly carrying out and providing the best of nephrology care services for the underprivileged section of the society, or at all the government institutes like be it Gandhi Medical College, Osmania Medical College, and NIMS. And what more, like we have the best hub and spoke dialysis service model overviewed by Dr. Gangadhar, where in even remote of areas of Telangana, there people have access to the dialysis facilities and also access to the cadaver program. Jivandan program of Telangana state is the best in the India. So what more, the actions speak louder than the words. This is what. And our unit is a very small unit. It's only of 3 to 4 years. And on the behalf of nephrology team, ASIC, Dr. Deepthi, Dr. Lalita, Karthik, and Dr. Ramya, I wholeheartedly thank Win India Telangana State Chapter and President Dr. Manjusha, Dr. Kiranmai Madam, and Dr. Priya for giving us this opportunity to present the nephrology services at ESIC. So ESIC, abbreviated as Employment State Insurance Corporation, is one of the two main statutory social security bodies under the ownership of Ministry of Labour and Employment, Government of India. Usually it is underprivileged for all the employees who are earning less than 21,000 or less per month, and for which they contribute, employer contributes 3.25% and the employee contributes 0.7%, with a total share of 4%. And all the IPs that is insured persons, get medical benefit, sickness benefit, maternity benefit, disablement, dependent, and funeral expenses. So all the medical, there is no ceiling. And the annual budget is around 80,000 crores across the India. So usually there is no ceiling, any expenditure, any cost we can give for our IPs. So ESIC across Pan India, around 145 ESIC hospitals are there with 1400 ESIC dispensaries and 8 medical colleges and 2 dental hospitals are there. And also they have an exclusive state government hospital partnership is there. Coming to ESIC Medical College and Hospital, Sanat Nagar, it is a medical college hospital has around 800 beds and super specialty hospital has 244 beds. And this Sanat Nagar hospital covers around 22 lakhs of IP population. And coming to the Department of Nephrology, though it started in 2013, it was at a very basic level where some basic OP services and IP services were provided, and majority of that was on the referral based system, referred to either NIMS or many of the private hospitals. But slowly after 2020, we had a new team, including me, who have worked in 15 years in corporate service, and we have joined as a new team, like all the doctors, 5 of us began the work from 2020. So slowly we have increased our beds to 25 IP beds, 5 ICU beds, and we see around 100 OPD. So the major challenges we're providing were first to start on the maintenance hemodialysis services at ESIC. Initially, 5 machines were there in 2019 for IP. And there was a MHD, maintenance hemodialysis program in the public-private partnership model. Nephrocare was taking care of it. But in 2018, it was cancelled. So around 400 patients at that time were referred to the NIMS and various tie-up hospitals. But due to the COVID and many other pressing issues, ESIC as Sanat Nagar has first started its own MHD unit. It's a unique in ESIC across India because it's always a PPP model or a referral model. Ours was the first unit to start ESIC run exclusively ESIC run MHD with 25 machines initially. And with this we started MHD unit with the single use dialyzers. We did monthly tests and all the routine things like all the medications like be it erythropoietin, iron, cinacalcet, or phosphate supplements, phosphate binders, everything were given to the bedside to the patient, to the dialysis patients. So there was increasing demand, so we had to do 5 shifts. With the 5 shifts, because of the odd timings, patients were having a lot of there was a discomfort. So we started providing ambulance services for them to pick up and drop for especially elderly people or some physically handicapped people so that it eases out their difficulty. So from there, but there was still a lot of increasing demand to provide services to all the IPs. So the major challenge was here for the procurement of the machines for us. Here in government, we had to procure machines from the GEM portal, which is a pan-India. Anyone can participate in the bidding. And there was an MII clause in which Make in India clause, as a result of which many of the major companies couldn't participate in it, and we couldn't go ahead with meet the demand of it. So what happened is then we approached Fairfax Foundation, which very with the great, we should say, the intention, they have donated 15 machines to us. So as a result, now we have 50 machines, 45 machines for the MHD. We are running still all the 5 shifts, 24 hours a day, and trying to still meet the demands, but still around 50 to 60 patients now are still being referred, especially the NIMS is supporting us with these patients. So from 2019, where we were doing around 400 cases a month, now we are able to do around 5,000, 4,500 per month. But as is said, sustainability. There is a lot of water scarcity in which to run so many machines every day, and our hospital was initially not designed to take so much of load. So now we are depending a lot on the water tankers, but I don't know, in the summer we are going to face a huge water crisis, and definitely there is a lack of space. In 115 machines in COVID times, the canteen was converted into hemodialysis unit, and for the positive, we are putting in the corridor. So this is the acute space crunch, and seeing the model of what Gangadhar sir has said, there's a remote controlling. So we are speaking with the ESIC, where we are trying to open up satellite dialysis centers at various ESIC dispensaries, like we have at various places, Nacharam, GD Metla, even at BHL. So there are so many places, so that we try to ease out pressure, and we have a remote dialysis monitoring system. So this is the services we have been doing. Then coming to the renal transplant services, again we have got live permission in July 2021. And first case was done in November 2021. Though we are around 2-3 decades behind, but this was the first program we have. And ESIC Sanatnagar is the first hospital across all the ESIC hospital in India to initiate the transplant program in hospital. So till date, we could do 12 transplants, and and we also got disease donor transplant permission. And first case was done in Feb 2024, and 20 days back. Again, the donor was from the Osmania General Hospital. At ESIC, we have all the drugs available, all the immunosuppression, speed, thymoglobulin, all the drugs we have. And we have in-house stack level assessment, and also CYP453A5 metabolite enzyme status, where we can know the metabolizer status in-house. So this is a great advantage as a unit we have in our hospital. And I should say that this is a personal interest, that this CYP453A was personally paid by our biochemistry, Dr. Imran. It is not, given support was not given from ESIC. This was a personal interest which was taken by our biochemistry head of the department, and he initiated this on his own money. So this was a support which we got from all the departments, across all the departments. So, but again, the huge challenge was to get the permission was an Herculean task for me. Like, only me and one MBBS doctor had to collect each certificates from all the departments. There was no support from the administration. It is only your interest and your passion will drive the things in the government organization. Otherwise, administration is not interested whether you do transplants or you don't do transplants. So it took almost 3 months to file up the application form and submit to the government of Telangana. And now the unique problem in ESIC is the authorization committee, which is manned by a regional director who is the chairman, then state medical officer who is an MBBS level, but he's at the state medical officer, and assistant professor of medicine, assistant professor of pediatrics and general surgery. So the whole workup file goes to them. And as many a times, because of various factors, because they are not a thing, the refusal of they refuse giving clearance based on biopsy is not there, or they ask for the child puke score, liver transplant thing, and many other factors which is delaying for me for the authorization committee as such. Means taking from 1 month to 1.5 months, because once they say no, again I have to write a mail saying that no, this is not required in kidney transplant. Then again a committee is constituted, again you do it. So in the meantime, I'm losing a lot of time. That is why I could do only 12 transplants. Otherwise, my target we work at least 1 or 2 cases a month. But because of all these procedures, it's delaying. So this is the challenge at the public sector, which I think, again, among the public sectors, it is only unique to ESIC, which is not seen in other public sectors. And also, I have to get an authorization or from the external expert nephrologist to say that this transplant is appropriate. So this is where these are all the rules framed from the headquarters of ESIC. So to change those guidelines, I'm working on that, but it may taking some time. So this is I'm not able to fill up the gap of working up the case and doing the transplant. Then CAPD and CCPD, peritoneal dialysis, we have 35 patients. The majority are placed percutaneous catheter placements by our own nephrology team. And complicated cases or pediatric cases, we take the help of urology team. That usually till a few months back, patient used to come monthly. We used to give all the consumables required for the patient in the OP basis. Even the cycler, transfer, everything was a smooth program. But because of some admin problem, there was a lapse in the rate contract. So as a result, the patient suddenly got deprived of all the supply. So now we had to again bank on Usmania General Hospital so that the patients get continuity of the care. So this is how these have been the challenges, and we have been taking the support of the other government organizations to help us. And the OPD also, it's a 70-80 per OPD. But the main challenge here is, of course, we have an online investigation system, trace the investigations, we have to online put a prescription. But for the patients, they have to take the drugs from the various dispensaries. The doctor is writing medicines at one level, they have to go to the other level, other hospitals, travel. Many patients don't travel. So there is definitely a discontinuity between the prescription and the practically at the patient level and the follow-up level. So this is and this also have been writing that the OPD prescription medication should be at our center. But again, because of the service, so many guidelines from headquarters, this is still being not implemented. Then IPD, we have 25 beds. We do all the procedures, be it, and our census has been, bed occupancy has been more than 120%. So all the procedures like perm cath placements, we have with the good team support, perm cath, IJVs, ultrasound guided biopsies we do. So around, on an average, though less from the other units, but still we are able to do good amount of interventional nephrology. Like interventional nephrology, I should say, my team, Dr. Deepthi, heads this interventional procedures, and she's very, very good at it. And she is training her the next PGs also. So we do in-house fistulogram, fistuloblasty, central venal canal stenosis. Also, we take interventional radiology help, and we try to cure at our hospital itself. Otherwise, difficult cases, we refer to the NIMS vascular surgery department. And for the first time, we have attempted medical thrombolysis 10 hectoplace, by which out of 6 AV fistulas which were thrombosed in acute phase, 3 we could rechannelize, and they are working properly as of now. So, and the main challenge, what I feel, is the procurement of the quality consumables, be it catheters, be it biopsy guns. Many a times I take on to the COVIDian type of thing, but because of GEM portal procurement or various things, we have a lot of problem. We do have a supply, but we have to multiple times we have to go to the admin to get a standard consumables. As we know, many a times substandard ones, it either costs at the patient level or they don't work. Finances are lost, but again at the practically we don't have any consumables. So I'm always trying to get a standard consumables at our level. Coming to critical care nephrology, we have 5 ICU beds, 2 CRRT machines of Baxter make we have procured. We do plasma exchanges, we have hemoperfusion. So all the quality care or high-end nephrology services which are available at other hospitals, even our IP population have equal access to them. So the DNB program was started in 2023, again initiated by Dr. Deepthi in our department. And we have got 2 seats allotted to us per year. And we have a regular teaching program. And apart with this, we also started initiating at the various research levels. Like we have with one study we are doing with the Magellan as a marker for the diabetic kidney diseases, early marker. Then we are working on the FGF hepcidin levels and hormonal levels, means various with the in part of this teaching program, we are looking at the various research activities also. In our challenging is to procure the kits of it, but still we are trying to get it. At the social level, at the community level, we are now taking up a project of screening for CKD in working community. We visit their workplace, industrial areas, check the environmental temperature, conditions, chemicals, what they are exposed, and to screen for the CKD prevalence and incidence in this population. And ultimately, it is because our ESIC community covers up the working population, we are planning to come up with the policy to the headquarters based on this. Then organ donation drive, very robustly we do it, educational programs can, and we talk to the group of people. Then as a part of it, there was a recent felicitation of the donors by the Honorable Governor of Telangana. So I think this was a very brief work, what we have, brief thing to say about work at ESIC. It's in the very, very beginning state, and in years to come, probably more we can try to do. Thank you, ma'am. Thank you so much.
Thank you, Dhanlakshmi. What an uphill task. I'm also reminded of how we started the Department of Nephrology in Andhra Pradesh in 1978 and had to do a lot of work. But then at the end, I'm sure it gives you a lot of satisfaction for what you have achieved. I now ask my co-chairs to give their comments.
Yeah. Good evening, ma'am. And thank you, Dr. Dhanlakshmi, for an excellent talk. I still remember 10 years back, I went to ESA hospital where nothing was there. I was also in faculty selection committee where Dr. Dhanlakshmi got selected and my student,
Yes.
Dr. Deepthi also got selected. They started very slowly, but as you see, the sturdy progress is there, and they have done what are the things as a tertiary care hospital has to do, from preventive care to transplant care, everything they have done, and it's excellent, commendable job where a personal intervention by a nephrologist can bring all these changes. Like Dhanlakshmi stood there, Dr. Deepthi also stood there, and they built the department where they're offering all the services from preventive to the curative to the all the other care. So I think this is a role model. Within 10 years you achieved, ma'am. I think we should congratulate you, because 10 years back nothing was there, I know.
No, sir, this is 4 years only. 2020, May we got recruited.
Yeah, but before that also
There was brief
there was
work.
some effort was there, then nothing was there.
Sushmita was there and we were there, but all the transplant and everything,
Yes, yes.
MHT
But
started off.
overall, over a period of 10 years, you have done that. I am talking about
Yeah,
ESA hospital, not about your individual. But I think it's an excellent proposition where you worked with all the admin people and you got everything done. And we wish you that you should steadily progress and take care of all the service of the patient's IPs, because 12 lakh IPs you have. Last time also we discussed like how to do about this hub and spoke model involving the other hospitals also. I think you can plan that. And we're always there. And NIMS, I think still initially actually we used to get all the patient from ESI to NIMS, but now our load is totally gone down. You're taken over. So we can serve other patients than ESI patients. So I think very good. And you can work on the hub and spoke model of starting dialysis in other areas where screen the patients there. Like you have a captive population of 12 lakhs. So that 12 lakhs health profile you can do and prevent the disease early, because they're all captive people. They're not other people. They are captive people are there, and definitely you can work on and do the prevention, early treatment for them, because all medicines are free in ESI. And treatment like high-end treatment like dialysis also you can plan an hub and spoke model where the IPs have more dialysis, then you can start there. I think you can take care of this 12 lakh captive insured person that you have. An excellent job. Thank you very much. Yeah.
Congratulations, Dhanlakshmi, and especially to you and your team. I know how you worked hard. You have done wonders, but I guess you will continue to do wonders and add regarding the transplant. I know you have a lot of hurdle, but I think you can achieve the administrative part of the transplant. So by next time, I think I would definitely see the increase in transplants also. The way you are working, I know it will be done by next year. I hope so.
Thank you.
Congratulations again.
Thank you. If permitted time is there, I would like to call upon Dr. Deepthi also, who is the main support system for me. Dr. Lalita and is there?
A quick comment, then Lakshmi, I think we are a little running late.
Yeah.
By about 30 minutes. Quick comment from the team.
Good evening, madam. Good evening, sir. Thank you for the opportunity, madam. This is all the constant support with Lakshmi madam, and admin staff also has supported us very much. And our then dean sir, Dr. Srinivas sir, he is a huge support behind all these things actually. So thank you, madam.
Thank you all the panelists. Thank you, Dr. Manjusha madam, for giving us this opportunity.
Thank you, everyone. That was an excellent session indeed. Now we'll move on to the upcoming panel discussion, where we'll like to know about the various the state chapters, what are their strategies to overcome the barriers and also achieve in providing a holistic patient care and patient-centered approach. For this panel discussion, I would like to invite Dr. Manjusha, Professor and Head of the Department of Nephrology, Gandhi Medical College, Hyderabad, and Dr. Swarnalata, Professor and Head, Department of Nephrology, Nizam Institute of Medical Sciences, Hyderabad, to kindly invite and introduce the chairpersons. And I would like to request the chairpersons to kindly introduce the speakers of this session. Would start with Win Kerala Group. Dr. Manjusha,
yeah, thank you,
kindly introduce.
Thank you. First of all, I would like to congratulate the entire
you.
WIN for such a wonderful program. So I think it's been a marathon of Penta Day activities. That it started with advocacy and then the quiz and then the international panelist discussion. And today we are having a state perspective. So I think the initial part of the program we have listened to how the Andhra, Telangana, and Karnataka has taken the initiatives, and it's a journey of challenges to overcome and reach a stage of equitable access to the kidney care with an affordable price. Now let us move on to what the other states has to say, particularly Tamil Nadu, the Kerala, and the center and the east zone. So for this, I would like to invite the chairpersons for the session, Dr. Narmata Rao. She's an additional professor in RML Hospital, Lucknow, and Dr. Smriti Sinha. She's the senior consultant and the Faridabad Hospital. Over to the chairpersons to take over the proceedings, please.
Hello, everyone. I think we've had a great discussion till now. Two great talks initially and followed by an extremely motivating talk by Dr. Dhanalakshmi. I think what she has achieved in the last 4 years is something, especially for us young nephrologists, it's like a dream, I guess. Since we are kind of back slightly short on time, I think we can move on to the panel discussion. This panel discussion will be basically about kidney diseases and state perspectives. India is a diverse country, both geographically and economically, and different sectors, including private, public sectors, and different states provide healthcare to their population depending on the resources available to them. Health policy itself is a state, it comes under state jurisdiction. So learning from different states, I feel will be a great way to go about it. Along with me to moderate the session will be Dr. Namrata. Dr. Namrata, would you like to say a few words?
I think we should start with the questions.
Okay, we'll start with the question. So I guess the first
One second. The moderators, the chairpersons, I think we should introduce the panelists.
Okay,
a quick
sure,
introduction to panelists. But before that, can I ask everybody to mute themselves? It's causing a lot of disturbance. Sham, can you mute everybody except the person who is speaking, please? Yes, Namrata, if you can just introduce the speakers or probably Smriti, just a quick introduction.
So to start with, we have Dr. Srilata. She is a professor in nephrology in Government College, Kozhikode. And also from Kerala, we have Dr. Gomti. She's also professor in nephrology in Government TD College in Kerala. So I think we'll start with the questions for the Kerala chapter first. And then as we move on in the chapters, we can keep introducing all the speakers. Dr. Srilata, what we would like to know is in Kerala, sorry. So Kerala being a state with robust healthcare systems in place, how is the system of referral patterns for kidney diseases? Do the primary physicians screen for kidney diseases, and do they commonly refer patients who have been found to have these diseases to higher specialists?
Yeah. Good evening, everybody. At the outset, I congratulate the Win India for organizing such an elaborate program in the context of World Kidney Day 2024. Regarding the referral pattern for kidney disease in Kerala, I should admit it is very late. Even in the state of Kerala with 100% literacy, we are proud of that, but still the knowledge about kidney disease among public as well as among physicians or general practitioners are very limited. The exposure to nephrology to these people are only for the theory exam during their MD course, that's all. So a small change of proteinuria, 1+ proteinuria or a creatinine of 1.5, 1.6, they are not at all giving any importance to this. They don't even communicate this abnormality to the patient also. So in general, the reference to nephrology is very late, usually at the time of initiation of KRT. And 25% of well-educated people with long-standing diabetes, hypertension, etc., they self-screen themselves and get referred to nephrology in the early stages of their disease. So that is the regarding the referral pattern. Regarding the screening for a kidney disease is not routinely done. It is usually done when patients get admitted for intercurrent illnesses. As a routine package of battery of tests, they do kidney function. That too only creatinine and urea, but not urine analysis. And some of the people, again, as I said, they self-screen themselves and find out their abnormality and get referred. So but in Kerala, most of the physicians use SGLT2 inhibitors and ARB as a routine, even though they don't screen and refer the patient. So that is an advantage in Kerala. I think to improve the screening program or early detection, the physicians as well as the public should be educated about the importance of early detection of kidney disease and the prevention to development of kidney failure. And I used to do kidney disease camps in the periphery of North Kerala, at least before the pre-COVID era, once in a month. Used to check the urine albumin, blood pressure, sugar, urine albumin, and creatinine, and give consultation to those who have some abnormality. And then I give a PowerPoint presentation in local language of Malayalam regarding the kidneys, their functions, how to detect the disease, how can we prevent it, etc. And ending the talk with the discussion on deceased donor organ transplantation. That was a routine, and now after COVID, I have started again doing I used to do once in a month in the periphery as a social service from my part at least. Okay.
Yes, ma'am. I feel the screening part, you're absolutely correct. In fact, what test to order also, is it urine albumin? I've seen a lot of reports of just urine microalbumin coming to you. They don't even know that it has to be a urine microalbumin.
Labs are also not aware about the albumin creatinine ratio or protein creatinine ratio. They just do the microalbumin per milligram per liter.
Yes, ma'am. So standardization of tests, screening of tests, what test to order, and especially with urine microalbumin, I feel that you're absolutely correct, ma'am, that at basal level, even MD physicians, in fact, for that matter, are not doing it.
No, even they are not familiar with.
Okay. My next question is to Dr. Gomti. Ma'am, what is the tentative ratio of nephrology workforce to the population in Kerala? And how are the dialysis services and transplant services delivered? And do the public funding support medications also? Are they free of cost, and can they are they easily available to the patients?
First of all, I thank the Win India for giving me this opportunity and congratulate the team for organizing this wonderful CME. So the first question is the tentative ratio of the nephrology workforce to population in Kerala. So there are 212 qualified nephrologists for a population of 35.8 million as of 2024. So that means one nephrologist for every 2 lakh population. So that is the statistics. And regarding the dialysis services delivered in Kerala, the Pradhan Mantri National Dialysis Program was rolled out in 2016 as part of the National Health Mission for the provision of free dialysis services to the poor. But in the state of Kerala, this PMNDP was not fully utilized. In fact, the fund through the National Health Mission was utilized for developing the infrastructure facilities, including those for procuring the dialysis machines. And there are this 103 dialysis units spread across the 14 districts of Kerala, performing around 48,000 dialysis sessions per month through the 1,121 dialysis machines. And this is given, in fact, free of cost to patients who are in the state insurance scheme. But those who are not in the state insurance scheme are also provided, but they are charged a nominal fee of 450 rupees per session of dialysis. But in many hospitals under public sector, this is an in-house program run by the local authorities. That is about the dialysis services provided in the state of Kerala in the government sector. Whereas as far as the CAPD program is concerned, it is the free of cost to all patients, irrespective of their financial status, through the PMNDP program since 2018. Approximately 510 dialysis patients are undergoing CAPD through this program, 450 through this PMNDP, and 60 patients are doing on their own, spending out-of-pocket expenditure. And if there occurs any shortage of disposables and consumables for performing the CAPD in the state, definitely these patients can procure this through their insurance scheme from the Karunya community pharmacy outlets attached to all government hospitals. Again, that's an initiative by the state government. So this through this insurance scheme, they can procure the disposables and consumables. And these facilities help the patients to undergo the CAPD program also uninterruptedly most of the months in a year. Regarding the transplant services delivered in the state of Kerala, there are 27 hospitals offering renal transplantation services throughout the state, out of which 5 are in the public sector. And irrespective of whether they live or deceased donor, in government hospital, major portion of the expenditure incurred in the performance of renal transplantation is met with by the CASP, that is Karunya Arogya Suraksha Pathadi, that is the insurance scheme of the state government. In addition, each patient will get approximately 3 lakhs rupees per transplant through this from the Chief Minister's Distress Fund. And these people again can apply for the same after a period of 2 years if they belong to the BPL status. And again, they will also get 50% of the cost of the transplant procedure also they will get through the MP's fund. And that again comes from the PM's Distress Fund. And many government hospitals procure the disposables, consumables for the transplantation program, especially for the BPL patients through the Hospital Development Society's fund, because many think that it is a prestigious surgical procedure. And in connection, it's also worth mentioning in this, in our state, as part of philanthropy, people contribute small amounts of amounts which in turn is collected by the local authorities, local bodies, and they are distributed to the patients. And the said cumulated funds are distributed for donor workup and for the maintenance immunosuppression for a pretty long period. So these mechanisms provide immense help for the poor and needy to undertake this expensive treatment option in the state.
Ma'am, what about the medications? Like, is it available free of cost to the patients, or especially for transplant patients, apart from the initial support? Because even in Bombay, they used to get initially 1 year, 2 year of support when I was there. But after that, a lot of them used to find it difficult to continue purchasing it. So are there any schemes for them, or are the medications free of cost or anything like that?
Definitely. Most of the medications they get through free of cost from primary health center onwards to tertiary care centers. Most of the medications are available. For example, the preventive drugs like anti-diabetic drugs, antihypertensive, including RAS blockade, statins, aspirin, and majority of the drugs are available. And only thing is that the recently recent nephroprotective drugs like flossins and finerinones are probably not available. And for the immunosuppression, government medical hospitals, tertiary care centers, through their hospital pharmacies, they are providing the mycophenolate, CNI, and steroids, but may not be available round the clock, but most of the time they will get. But if at all they are not getting, they can procure it through their insurance scheme. That state government insurance scheme they can procure. So most of the medicines are available.
That is commendable, ma'am. There's a lot of support, I feel, for the patients. We'll move on to the next state chapter. And if there is time in the end, then we will come back to follow-up questions. Moving on to the next state chapter, which is Tamil Nadu. Sorry. We have Dr. Jayalakshmi. Dr. Jayalakshmi is professor in Institute of Nephrology in Madras Medical College, Chennai. And Dr. Ranjini, she's a consultant in Apollo Hospital, Chennai. Hello and welcome to the panel discussion.
Thank you.
Madam, I'll start with Dr. Jayalakshmi. Ma'am, about Tamil Nadu, how do you think is the kidney dialysis care, including your peritoneal dialysis as well as hemodialysis services and transplant services in Tamil Nadu, specifically in terms of how has it been made accessible to both the poor as well as the poor population as well as the people who can afford it in private? Maybe from the government perspective, we'll talk first. How do you think it is well distributed?
Actually, I've sent 2 slides. Is it possible to
Yes, ma'am. Can we get ma'am's slides? Yeah.
Yeah. See, basically, first of all, I thank for this great opportunity to talk about the health services in Tamil Nadu. A wonderful attempt by Win India.
Madam Dr. Jayalakshmi, can you just move closer to your device because your volume appears to be a little low? Yes, madam, please go ahead.
Is it okay now?
Yeah, a little better, madam. Please go ahead.
At the outset, I thank Win India for giving me this wonderful opportunity, and I congratulate Win India for this wonderful program. Basically, in Tamil Nadu, we have the government hospitals offering all the treatment free of cost, and we have the CM insurance scheme through which we procure the medicines and disposables required for the patients. As far as dialysis is concerned, we have medical colleges where dialysis is being done. We have 40 of them. We have 40 medical colleges where dialysis is being done in all the medical colleges. Apart from that, we have other centers where we have district headquarters hospital, about 32 of them, and sub-district hospitals, little lesser than the district headquarters, 58 of them are there. And urban centers, the private-public partnership, the Tanker Association, they actually have 8 centers which cater to these people. And standalone centers, we have 130 standalone centers which do only dialysis, which are hooked up to the nearby centers where a nephrologist is available. And all these dialysis is covered by the CM insurance scheme, where the patient below poverty line is actually given a card through which the centers claim the amount that is approved for the dialysis. Then we have district number of dialysis machines in the whole of Tamil Nadu in the government sector is around 1,202. And the number of nephrologists is around 220. And the population of Tamil Nadu is 8.4 crores approximately. And number of dialysis done per month, the average cycle is 62,273. It's an average, somewhere about 60 to 65,000 every month. The great thing that I would like to tell you is none of the patients have to spend out of their pocket. All the below poverty line people are taken care of, and they get free dialysis and free medications. In all the medical colleges and all the government institutions, anti-diabetic drugs, anti-hypertensive drugs is being given free of cost, and regular screening is also done. They have small labs set up in the smaller hospitals, and bigger hospitals have more equipped labs. So the screening is also done there. The physicians are given periodic training to find out the complications of diabetes and hypertension. Can we have the next slide? We have a nice thing called Makkalai Thedi Marthuvam. That means medicine or medical treatment at the doorstep, where there are volunteers who are MTM nurses. They are actually paid by the government. They volunteer to do this job. They go to the doorstep of every individual in a village. There, they see if the patient has got any issues with respect to diabetes or hypertension. They just do a minimal test. They check the blood pressure. And then they also, whenever somebody's got a wound and requires regular cleaning and dressing, that also they do. And anybody who's bedridden, they take care of them also. So this Makkalai Thedi Maruthuvam has really done a lot to reach the people who cannot reach the hospital. So with this, we have actually, we are able to do a lot with CAPD, because in CAPD, the problem is the patients have a little inertia when they have to take care of themselves at home. So they don't opt for a CAPD because they feel they are not supervised adequately. So these MTM nurses go to the house and they supervise the CAPD, how the patient does, and how, I mean, we have regular meetings every month to see whether they are doing it properly. Then we have DMOs who are the next level people who monitor these people, and they give adequate instructions. And these are all tagged on to the nearby hospital where a nephrologist is available. So this hierarchy is maintained, and every month these people go to the nephrologist to have a regular checkup done and get their bags free of cost. And that is actually routed through the CMCHIS. So the Chief Minister's Health Insurance Scheme, along with the PMJ, together we have schemes for all these things, and it's being properly utilized. Then coming to renal transplantation, regular live-related transplantation is done in all the medical colleges where nephrologists and urologists are available. Coming to the disease donor transplantation, actually it is taken up. It's been actually in the recent past, I should tell you that we actually had a good number of disease donors coming up, and which is regulated by the Transplant Society of Tamil Nadu. We have actually transplant centers which are 13 in number in the government sector. But we have retrieval alone centers where there is no facility to do a transplant. But when a brain death is recognized in that center, when a brain dead patient is recognized in that center, they can do organ retrieval. So they are given training and they are given license to retrieve the organ and sent to the nearby places. So that actually is a great thing, because so far these places were not utilized and the patient could not be transported to the higher center after the patient is brain dead. So therefore, these retrieval centers are a wonderful thing where we are able to get more number of organs. So we should say that in the last year, in 2023, we had 178 deceased donors. And in 2024, from January 1st till date, we have 60 deceased donors. So we actually take the kidneys, liver, heart, lung, and intestines at some time, and corneas are usually harvested. So this is about... Yes, madam.
Yes, ma'am. Commendable job, especially in the disease transplant sector. I feel the biggest challenge is to get people to donate kidneys and to be able to convince so many. I think it's a great job done by the Transplant Society. The awareness is starting from...
Main thing I would like to tell is that we actually have something called a honor walk for all these deceased donor people. So what we do is the institutional people, they actually, as the organs are harvested and the patient's body is handed over to the patient's attenders, we have a honor walk from the mortuary until we we put the patient to hand over to the attenders. And this is done by the people who are working in that hospital. And in our hospital, periodically, almost I should tell you, every time the head of the institution, our dean, then our chief, and whoever is involved in the transplant, they come, they pay respect. And this is actually caught up a lot. And the government has also announced that everybody will be given respect. Supposing if it is a district headquarter hospital, there the collector goes and places a wreath on the patient, on the body of the donor. This actually has become a little sensational. People really know that they're honored and they know the value of organ donation.
Yes.
And one more thing I should tell you is that in the transplant sector, we give all the medicines free of cost. And even people who have got transplanted outside in the private sector, sometimes what happens, they get transplanted, but as in the course of time, they are unable to buy medicines. So these people also can approach the government, and a special GO will be passed asking our people, the government people, to give the medicines periodically. As and when they require, every month they'll come and collect medicines from us. This is also being done by the government.
Yes, ma'am. A lot of support from the government, and the results are quite visible. Now, moving on to Dr. Ranjani, diabetes has become common, or in fact, it is the most common cause of CKD currently in this country. Almost 50% cases of CKD is because of diabetes. So how does Tamil Nadu healthcare system strategize the renal care in diabetic patients? Are there any special schemes for diabetic patients, especially related to their kidney disease, screening or treatment? What would be your take on this?
Thank you, Smriti. Thanks for the opportunity, and congratulate truly the WIN team for organizing this. Tamil Nadu has been a pioneer in healthcare, with the oldest medical college being there, and also the first transplant was done at CMC Vellore. So we also have a strong health policies, and also all the medical colleges and government hospitals are well equipped with diabetic clinics available. So according to estimates, around 1 crore individuals in Tamil Nadu need medical support for hypertension and diabetes, and only 20 lakhs visit the health facilities, and remaining 80 lakhs somehow don't have access because of various reasons. So with the aim to facilitate the wider reach and bring down the health-related death related to the non-communicable diseases like chronic kidney disease from 5 lakh to around less than half per year, Tamil Nadu government has come up with something called as doorstep kidney care model, which has already been highlighted by Dr. Jayalakshmi, which is the Makkal Thediya Marthuvam, where I think it means that taking the clinic to the people's home. So it includes home-based dialysis units where PD kits are being made available to the people. Also, home-based physiotherapy is being offered to individuals who cannot make it to the hospital because of infection or any amputated leg because of long-standing diabetes and its complications. And also, we have a mass screening program to detect this hypertension and diabetic based on simple tests, based on the albumestics and the protein leakage, the ACR levels. We diagnose the diabetes and hypertension, and based on which the medications are dispensed free of cost to the individuals, and follow-up is mainly done by the community health workers at home. So when the medications get over, the healthcare workers visit the home of the individuals, and again at that point of time, in addition to giving the medications, they screen the individuals again for diabetes and hypertension, whether they are adequately controlled or not. If in case they find some erratic readings, or if the control is not adequate, then the patient is being referred to a higher center. So in this way, patient is able to reach the hospital at a little early stage, and early referrals helps to prevent the complications. And also follow-up is ensured because the community healthcare workers is involved. He or she not only gives a medication, does the screening, but also gives free advice on lifestyle, exercise, and also about reiterating about adherence and compliance, which is important for any chronic kidney disease, which is a long drawn process, and any point of time patients can lose their interest and they can lose their enthusiasm. And also, as told by my colleague, peritoneal dialysis is an essential part of the CM Health Scheme. So this has helped in a great way to improve the access to the healthcare, effective utilization of resources, early referral to the specialist, and prevent the complications and death. This was based on a pilot project which was done by private practitioner Dr. M.K. Mani, the pioneer in the field of nephrology in the South, who actually had adopted 48 villages and covered around 50,000 individuals. He had gone to those places, villages, and done simple screening in the form of glycosuria, and protein levels in the urine were checked based on the dipstick levels, and based on which it was diagnosed. Blood pressure was also checked up on, and based on which the patients were given low-cost medications at a very affordable, very cheaper drugs were being offered for the control of blood pressure and diabetes. Like glibenclamide was only offered, Reserpine, he was very fond of Ramipril, so the same brand was being given. In case individuals who needed complicated tests, they were sent to Apollo, and then they were given free tests. They were offered free tests, and they were managed adequately. And this was done for almost 8 years. And at the end of 8 years, they saw that the outcomes were quite good, quite alarming also. And 96% individuals had good blood pressure control. Around 52% had HbA1c levels less than 8. And almost they could prevent around death from around 33 people per 1,000 in the villages, which was not screened well. to around 8 per 1,000. So this was a tremendous improvement, and also this project was well appreciated by the International Society of Nephrology also, who had come and made a personal visit to the at a ground level. And finally, it was considered as a project which should be widely propagated and followed upon. So based on this only, we had this Makkal Tedia Martuvam with a whole door-based kidney care treatment, and which has become very quite powerful, and it has reached many individuals, because diabetic is a very common disease, and I think every third or fourth individual in the country is a diabetic, and it is important to screen them early and pick them early to prevent the complications. And also, in addition, we also do some teleconferencing. So not only at the government sector, the private sector also comes to the fore and does teleconferencings, and it reaches various individuals at a rural level also. They can be in touch with the doctor. There's an integration of the physician with the consultant, so that the confidence and trust is being maintained, and when physician has the trust, then only the patients will have the trust to continue the drugs. So it is important to reiterate that also. And involvement of all the grassroots level of people to the hierarchy is very, very important. And also doing a CME program to keep things updated and keep the physician updated about various new drugs which are available, and importance of early referral. All those things has been thought about and taken into account.
Yes, absolutely. I think there is just so much misinformation about diabetes in the general public that by the time they actually reach nephrologists or any physicians, they have already gone through a plethora of different kind of treatments, be it alternative medicine, and they have their own notions about it. So actually involving the nurses at grassroots level, going to them, reinforcing it again and again, I think is a brilliant idea, and that is what is needed. Just one-time visit with a physician you might not be able to get through to the patient, and that trust factor might not develop. So the entire holistic approach, I think, is a brilliant initiative. And of course, there is also research to back up the impact of it. So this is a good thing that we maybe can copy in other states if we get the kind of support. Thank you so much, Dr. Ranjini and Dr. Jayalakshmi. Moving on to the central and the east zone, I now request my co-chair, Dr. Namrata, to please moderate the next two sessions.
I'm the moderator and not the co-chair. So that's it. Anyways, I now invite Manjari ma'am from Guwahati Medical College. And basically what possibly, the Northeastern India, which many of us, sort of do not know much about, as to how, ma'am, I would like to ask you regarding how have the kidney services been imparted during the last 30 years in the Northeastern part of India? Are there, existing state government policies which look after these aspects, and which of, if any, of the central government policies are applicable there towards kidney care?
Okay, thank you so much. And thank you, Win India leaders, especially for conducting this seminar on World Kidney Day, on the occasion of World Kidney Day. I was extremely busy with my World Kidney Day celebration and organization. I am happy to inform you that tomorrow morning we'll be holding one walkathon from my hospital in the morning at around 7 o'clock to generate awareness amongst common people about kidney diseases. Then there will be an awareness meeting in my hospital where I'll be addressing the people who will be attending the OPD, not only nephrology, all the different OPDs. And that will be also addressed by the Roto director, the urologist, and other eminent personalities of my hospital. Thirdly, I'm arranging one free health camp in a remote village, not tomorrow, but on Sunday. Usually I had been doing this since last 2 years, where what I do on the occasion of World Kidney Day, I go to a village and I do free health camp, and where I screen those patients, those people who attend the camp. And we have been able to pick up a lot of undiagnosed CKD patients. So maybe at the end of 5 years, I'll be in a position to give the exact picture what we have been doing. Now, when we talk about the Northeast, you must be knowing, but I still want to say that Northeast comprises of 8 states. It comprises of Assam, Manipur, Meghalaya, Mizoram, Nagaland, Tripura, Sikkim, and Arunachal Pradesh. And when we talk about the Northeast, the only state that is developed in comparison to the other states is Assam. And then other states after Assam comes, I think, Manipur. Manipur has also a good number of nephrologists. As of now, there are about 8 nephrologists. And when we talk about the region, somebody right in the beginning was talking about the different types of geographical problems we have. North is such a region that there are a lot of hilly states, and there are only few states in the plains. So there are very difficult terrains. So there are some places in North, especially in Arunachal Pradesh, when we talk about that, I have seen patients walking for one full day on foot, coming to a place where they can take up a bus. Hello, am I audible?
Yes, ma'am.
Yes, ma'am. You are.
Yeah. So they walk on foot for a day, come to a place where they can take up a bus and come over to Guwahati to seek medical attention. Very sad to say, out of all the Northeast states, only Assam has got the maximum number of nephrologists. There are about 20 nephrologists. There is only one nephrologist in Arunachal. She just joined recently. She was my student. She joined in the month of January. There is one nephrologist in Nagaland. There are 2 nephrologists in Mizoram. There is 1 nephrologist in Meghalaya. There are 8 nephrologists in Manipur. There are 2 nephrologists in Tripura and only 1 nephrologist in Sikkim. So regarding that, in respect to other states of India, we are very, very, no, I will not say backward, but we are not up to date in comparison to the manpower. Because Northeast as a region, it covers an area of 262.179 kilometers square. Assam being the largest has a population of 34.59 million as per the 2021 census. So if you want to figure out the population nephrologist ratio in Assam, that would be 1.1 per million population. So can you see the dearth of nephrologists that we have in this part of the country? And if you have to go down to the rural area, then the ratio of nephrologists to the population will be as low as 0.06. So we need to build up the number of nephrologists in a state. However, with the scarcity of all the nephrologists and specialist doctors over here, Assam is doing quite good, and I'll be in a better position to mention about what we have been doing in Assam. So in Assam, there are 7 medical colleges out of 12 where dialysis is being done. Also, dialysis machines and dialysis facilities are available in the civil hospitals, in the referral units, and in 2 model hospitals. Out of the 28 nephrologists in Guwahati, in Assam, let me say in Assam, the majority are in Guwahati, and 3 nephrologists are in the district of Dibrugarh. Dibrugarh is a part of Assam. So that comes to 20 nephrologists over here. But we have a good number of dialysis units. Actually, after this Pradhan Mantri dialysis scheme, a lot of centers have been picked up by the government to provide dialysis to the people in the remote places, and the number of dialysis patients are increasing. So there are 41 dialysis centers in the government sector, and there are 24 dialysis centers in the private sector. When we talk about dialysis center, obviously we have to talk about the machines. So we have about 249 machines in the government sector and 145 machines in the private sector. And the average dialysis that is done in my hospital, that is Guwahati Medical College, is 1,700 per month. Initially, when I joined my service way back in 1995, just after passing my MD, so there were only 4 dialysis machines, and we hardly had maybe 6 patients a day, hardly. We used to have just 1 or 2 patients. So that number of patients increased to 1,700 now. So can you imagine the gravity of the situation, how CKD is becoming rampant. It has become a global epidemic, all of us know. And Assam is also not behind that. So number of CKD patients are increasing. Number of dialysis patients enrolled in the government sector as of now, which I got the data, is 2,600. So talking about the sessions, it's 1,700 sessions a month. But the number of patients that have been enrolled in the government maintenance hemodialysis centers is 2,600. But the good part is that patients whoever are availing dialysis in the hospitals and in the different government centers, the dialysis is absolutely free. However, the private hospitals, I think they're charging from 3,000 to 4,000 rupees per dialysis sessions. Regarding transplantation, again, I want to say, I'm sorry to say, the transplantation is done only in my hospital. We have been doing that regularly since 2013, but in none of the government medical colleges, transplant is being done. Secondly, transplants are done in few private centers, but again, I'm sorry to say the transplant centers, surgeons actually, they come from outside the state. There are no in-house transplant surgeons except in my hospital where we have an in-house transplant group. The transplant is being done by the Department of Urology. And also I'm happy to say that we have been able to start the disease organ donation program on the 13th of December. So we can include the name of Assam can be included in that list where it was initially shown that there is no disease organ donation taking place. We've done 2 kidney transplant over there. Transplant medicines in most of the other states have been mentioned is also free in my state. And the transplant program is and the dialysis program who are actually not in the BPL. So they are availing the Ayushman Bharat card where the government allows or gives an amount of 5 lakhs rupees per year to that Ayushman Bharat card holder. So transplant is also, you can see, is free in my center. Dialysis is free in my center. Post-transplant, they're getting all the medicines free. And regarding CAPD patients, as of now, the total number of patients enrolled in the CAPD program in my hospital is 270. CAPD fluid is free to these patients who have availed or who have started the CAPD program in my hospital. Few patients who started the CAPD catheter insertion or CAPD program outside the state, outside my hospital, but they belong to the low economic class, and if they can provide those documents, to them also the CAPD consumables are supplied free. So this is all about the about dialysis facilities, transplant facilities that we are trying to provide to the state of Assam. There is a movement, I should say, there's a lot of improvement in the dialysis and kidney care facilities which we are trying to give to patients. But in comparison to the other states, I think we have to do a lot more. That's all I have to say.
Ma'am, that's truly commendable, and there are a lot of lessons. In fact, for somebody from state of UP to learn, because in spite of being a much larger, more populous state, right in the plains, we possibly still have problems with outreach of services to the poorer sections of society, and diseased organ donor transplants are also in a very nascent stage for such a large state as ours. Now I'll thank you, ma'am. Thank you for sharing your experience. Now I'll move on to Dr. Aruna Acharya, Professor and Head, SCB Medical College, Cuttack. Good evening, ma'am.
Good evening, everybody. Thank you,
yes,
Win India, for giving me such a big platform to speak, and I'll congratulate all the Win members conducting such a beautiful awareness and very enchanting topic. So I'll tell about Odisha. Odisha is having very fast growing and advanced health system, so to say. So our health government is providing, there are many schemes for the kidney patients. So the slogan given by our Honorable Chief Minister is every life is important. Pratyek Jivan Mulyavan. So in that slogan, the state government included many schemes for the kidney patients, like the Biju Swasthya Kalyan Yojana, that card will provide if the patient is a poor patient and from the remote village also, that can get that patient can get the service in the very high corporate hospital, about to 5 to 7 lakhs for a male patient and around 10 lakhs for a female patient under that BSY card, even in the corporate hospital. And in the government hospital, all the facilities starting from the OPD, from the hemodialysis, CAPD, then the kidney biopsy, transplantation, every service is free. And under Niramaya scheme, all the post-transplant and every treatment given to the kidney patient is given free of cost. Then with Sahaya Yojana in all medical colleges, including the government medical colleges, they will get the free dialysis service. And under the Rahi Care service, all the district headquarter hospitals, the subdivisional hospitals and the CSC level, the dialysis machine are installed, and the people from the remote village, they can able to get the dialysis service at their doorstep. And in the government medical college, there time to time there is awareness program, there is teaching program, there is dialysis technician training program, and time to time the government has made the task force, the team of the nephrologist from the medical college, they will visit the hotspot area in the Odisha. There is CKD EU, they will screen the villages and they will just pick up the cases, the satellite cases in the family and in the village, and those patients will be intervened very early stages of the CKD when the creatinine is just 1.5 and proteinuria 1 plus. And usually in our state, the CKD-U patient, like other, they are young, usually male members, 20 to 40 years, yearning person of the family, and usually these patients are non-hypertensive, non-diabetic, and there is no edema also, only dyslipidemia. In mild there is hyponatremia and sometimes hypokalemia. So in many cases we have done the kidney biopsy also, nothing more interesting. In some cases FSGS is there, in some cases CIN, in some cases glomerulosclerosis, all those things are coming. So those are also supported by our government. And regarding the kidney transplantation in Odisha, it started from 2012 onwards. Till now we have done many kidney transplant live related. And in our state, from 2020 onwards, we are doing the deceased donor kidney transplantation program. We have our own SOTO established in 2019 onwards, and we are with the help of SOTO, we are doing the deceased donor organ transplantation. Till now 20 deceased donor organ transplantation has been done. Last week we in Odisha we did 4 back-to-back deceased donor multi-organ retrieval, and 2 from my institution SB Medical College. And to enhance that deceased donor program in Odisha, the Odisha government is giving the Suraj Award, that is around 5 lakhs, the financial benefit for the family of the donor, the deceased donor family. They will give in that benefit from the state government. Along with that, now in previous month, our government has decided to give, and we are giving also the guard of honor to the deceased donor at the last rites. So, and the post-transplant medications are free of cost, lifelong, and that is provided by the state government. And the hot spots, usually there are many hot spots in our state, mainly near the Narsinghpur, Badamba, and the in the Anugul, Dhenkanal, and Balangir, Bargad. In those areas, the government is giving time to time screening programs, then picking up the cases, then drinking water, the screening, and the name of the family and person, they are enrolled in the state government, and the facilities are also given to them. And many people are brought to the nearby government medical college and screened, and if possible we are doing also kidney biopsy. So all the facilities in the state of Odisha is given by our state government, and the state government is proactive and is very, very supportive, and whatever we want to give for the patient, and the government is very much active, and immediately all the facilities are provided to us immediately, and the benefit to the kidney patients are given by the state government. So I'll thank my government, and thanks to the WIN.
Thank you, Dr. Aruna, for sharing your wonderful experience. Sometimes we get a lot of positive outcomes, especially from the government too. It's not like we always need to have them under a scanner. Now, moving on to Dr. Padmini from Indore. Dr. Padmini, I'd like to ask you regarding how are the national programs of dialysis being put to use in the state of Madhya Pradesh? And how is it? I know it's a sister state to us. How are the transplant services there and how are they being strengthened? Dr. Padmini, please.
Thank you, Namrata. And first of all, I would thank Win India for giving us this opportunity because Madhya Pradesh is usually not looked into and in the national scenario. We still have to go a long way before we can make our mark. But as far as the dialysis facilities in my state are concerned, I would like to share this experience that mostly the kidney-based facilities in Madhya Pradesh initially were more in the concentrated in the private sector. It is only after coming up of the national Pradhan Mantri National Dialysis Program that the dialysis facilities that are being available in the government sector, and these are both the in-house and the PPP model, because the PPP models are being taken care in the periphery by the Apex Kidney Institute, and the government dialysis facilities, whatever the government is providing, is basically free of cost. But in spite of that, most of our patients remain on 2 per week dialysis because they have to travel large distances before they could come to the nearest dialysis center. This is in spite of the fact that all the 52 districts of Madhya Pradesh are having their own dialysis units. And it is not only hemodialysis that is provided by the government, they are equally supporting peritoneal dialysis also. But the number of patients on peritoneal dialysis are pretty less. And when the patient comes for hemodialysis, he also gets an access to the major medicines in the form of antihypertensives, and even erythropoietin supply is there from the government. So that part is also taken care of. But in spite of that, the number of people who are on dialysis or who actually after starting dialysis fail to maintain themselves on dialysis is because they have to travel large distances. So probably we'll have to work more on the peritoneal dialysis program, which is also equally supported by the government. The catheters that are there are also supplied by the government. And like one of the speakers had mentioned, that the quality of these catheters at times raises question, but at least we are being able to provide all these facilities to our patients through the Ayushman Bharat scheme. And you have the Ayushman Bharat card, which is acceptable at not only the government sector, but also in the empaneled hospitals, which are doing dialysis through this. Then apart from the Ayushman Bharat scheme, there is a MP Dialysis Seva scheme that is run by the Madhya Pradesh government. And it covers again the poorer and the weaker sections of the society, where free of cost dialysis is provided at dialysis centers. And there are for people who do not exactly fall below the BPL line, they can get dialysis at these centers with a minimum amount of 500 rupees. Obviously, in the private sector, if you go, the dialysis costs become around 2,000 or 1,500 rupees for each session. So more or less, it is the hemodialysis which is dominating the picture in Madhya Pradesh. Peritoneal dialysis we have to work on because the western part of Madhya Pradesh and even the eastern part of Madhya Pradesh are significant tribal zones where the patients have to travel a lot before they can reach dialysis facilities. And like one of these speakers was mentioning, that if you have you can provide them with some amount of transportation and bring them to dialysis centers, that would definitely help in this regard. And coming to the transplantation scenario, it's interesting to know that transplantation in Central India, Indore was the hub of transplantation activity, which is also happens to be my hometown. And the renal transplant started there in the late 1980s, but that was all concentrated in the private sector. It is only in the government sector that last year the first government hospital did it at Bhopal, and then subsequently we have done it at Indore and Gwalior also. These transplants are covered under the Ayushman Bharat scheme in government hospitals, and you get a total payment of 5 lakh rupees in which you have to manage both the induction and the maintenance therapy. And subsequently, the as far as the transplant medicines are concerned, if you're doing it in the government sector, the government is providing these immunosuppressions free of cost. But yes, if the patients are transplanting themselves in the private sector, then obviously they have to pay from their pocket. If you look at the scenario, the figures last year, there were about 243 live transplants. These were live related, mostly ABO compatible. And as far as the disparity in donor and recipient is concerned, we have more male recipients getting kidneys from female donors. As far as the female recipients are concerned, they are little bit lagging behind, because it is usually the mother or the sister who agrees to give kidney. Otherwise, they find it pretty difficult to get the kidneys from their spouses, which may not be the case when a male recipient is there. But nonetheless, that scenario is improving. I think a commendable job has been done by the various awareness campaigns that are being run, and some of the local authorities who have supported the transplant program, the local authorities in the form of local district administration. And with the help of that, like in my own place, there is a Indore Society of Organ Donation, which helps when it comes to disease donation. And we establish a green corridor. And with this green corridor, a number of cadaveric transplantations have gone up, in spite have increased, but actually a lot needs to be done in this field. And these green corridors, not only it's within the city, but even some of the liver has been flown to other parts also. So this is basically the scenario as far as transplant is concerned. Mostly concentrated more in the private sector for the time being, but we are working that we give a free access to our patients and good care in the government sector too. So over to you, Ranjana.
Thank you, Dr. Padmini, for your insights. It looks like a lot of work is being done at the moment in your state. Moving on to Dr. Isha, who's also from Indore. Dr. Isha, would you like to suggest some recommendations that you would make to your state government, considering that they're already going the extra mile, which would help in combating kidney disease and improving kidney care?
Yeah. So at the outset, again, I would like to thank Win India for providing me the opportunity to speak here and represent Madhya Pradesh, which, as Dr. Padmini has stated, is often underrepresented. So I would say that ours is a rather developing state in a developing country with a contribution of around 4% to the GDP. And as she said, we have a large chunk which is actually a tribal population. To iterate the statistics, we have around 25% of people who are living in tribal areas of Baitul, Shahdol, etc. And talking about the central zone, even Chhattisgarh is a part of it, and Chhattisgarh is predominantly about the tribal areas. So it is difficult, and it is actually not expected out of us that every nook and corner and every pocket of such areas will be covered, and everybody would be aware of the symptomatology and the reach would be widespread. So yes, there's a lot of lacuna in that regard, that the reach of information, the IEC activities should be enhanced as far as the state government is concerned. Because if I quote an example, which I could recently come across in my OPD, there was one 14-year-old boy who walked in with severe knock knees. Now, when I inquired and saw his investigation, his creatinine had gone up to 14 and he wasn't even aware of it. And for the knock knees, that tribal boy was actually roaming around, knocking the doors of orthopedic surgeons, and he had no respite. So that way, the awareness itself that it was all because of the worsened CKD that he had developed this MBD was actually not there. He had a good urine output, so he was not even aware that this could be a spectrum of CKD. So that way, awareness has to be increased. The IEC activities have to be increased by the state government, because anyway, as we compare to the southern states, because I have done my DM from Nizam's Institute and Hyderabad, and southern state for that matter, they have better facilities with regard to health, and the things are more streamlined there. So we have areas of work where there are a lot of shortcomings, and that way the awareness activities by the state government should be enhanced. Apart from that, one thing which was a takeaway from NIMS and Hyderabad for that matter was that they had a good hub and spoke model. So the hub used to be at the at NIMS, and the spoke were at various other districts which were run and monitored and supervised, and the patients actually everything was answerable to the hub part. So that thing can be it's a super model which could be simulated in states like ours, where actually the facilities are less. So the hub centers can be created which would supervise, manage, and run the spoke, and hence there will be some answerability and credibility as far as the peripheries are concerned, and monitoring, surveillance, etc. would also be enhanced. So over to you, ma'am.
Thank you, Dr. Isha. Dr. Smriti, would you carry on with the next session, or is it like, I mean, I think there are some issues with regard to the timing.
Yes,
I think we should ask Dr. Manjusha ma'am whether how much more should we be overshooting.
Yeah, I think, yeah. I mean, it's a great session, but nevertheless, unfortunately, since we are running behind the schedule by about half an hour, I think we should wind up this session. Apologies to the panelists that we are not able to take this second round of questions, but nevertheless, the information that you have given from each state is enormous, notable, noteworthy, everything. So I think we should hold on the second round. And please, the moderators wind up so that we come to the end of the session and close the session. Moderators, if you have to say anything, Namrata and Smriti.
No, and I think the questions were very useful. So we had a good time listening. There's a lot of general knowledge too. Nothing more to add. Thank you, ma'am, for inviting me. Thank you.
Yes, I know. Like Dr. Ranjani has said in the comments, this was like a NDTV Times Now session where I think everyone got a snapshot of what everyone is doing. And I hope that, like, at least I have personally learned a lot, especially the work that is being done by at ESI and in the South, and how they've convinced their governments to pitch in at ground level to the upper tertiary care. And I think, ma'am, thank you so much for organizing this for us. I think, true to the theme, this was a totally enlightening session, and we stuck to kidney health for all. Thank you, ma'am.
Thank you so much. I think there is a lot of accomplishment from the Win India, like, I mean, with the Win India state chapters, which have stepped in to share their services, starting from Northeast to the Madhya Pradesh, to the South state chapters, of course. There's a lot of information and insights, and of course, a long way for us to go. But nevertheless, I think this much amount of information cannot be shared on any other platform other than this platform. So that way, really thank everyone who has joined, and then you have taken your time. It's not easy. It's not easy preparing questions. It's not easy collecting the info. Truly appreciate Dr. Jayalakshmi, I mean, Kerala teams, and also Ranjani and the central teams, and also the Odisha and Manjuri sharing their precise information with regards to the workforce, which is truly a challenge for us. You know, I mean, the number of machines, the number of the doctors, it's not an easy task. So a job well done. And of course, the way you are taking the nephrology services across your state is really commendable and truly appreciable. So I am really glad that you have all joined and you have done the best. And of course, the didactic talks that we had as the earlier part of the session was truly inspiring. And from our own state, everybody has been speaking about the hub and spoke, including Isha, who is from the central zone. So, I mean, we can understand that the success of such an innovative model takes us to certain heights where the very precise theme of the World Kidney Day, that is kidney healthcare to all, accessible and equity services to all, is reachable to every nook and corner if possible by this hub and spoke. So thanks to everyone who has joined. Really grateful to you, all of you, all the panelists, as well as the speakers and the chairpersons who have joined in the earlier part of the session. Thank you so much. Over to Kajri for closing the session.
Yes, ma'am. Thank you everyone for taking out their time and joining this session. To have a short recap, we got a very good snapshot of the various state perspectives. And to have a short summary, we know that prevention is better than cure, and we must encourage the young nephrologists to take up the preventive nephrology. And we recognize that there is a gap between what we know and what we practice. So though there are new drugs that are available for the CKD armamentarium, still there is a long way for us to go to implement them in regular clinical practices. So we should recognize the barriers and try to overcome them. We should incorporate digital literacy and connection with the primary care physicians and telemedicine. And I would like to thank Dr. Manjusha Yadla for organizing such a wonderful webinar and Penta Day activities. And at the end, I would like to invite all of you for tomorrow's session, last activity of iWin Chat at 9:30 p.m. tomorrow. So please be on Twitter and support the program. I heartily thank you all for taking out your precious time. And I would like to close the session. Thank you all.
Thank you, madam. Good night.
Thank you so much. Good night, everyone. Thanks, Shyam. Thank you so much. Thank you, everyone. Good night.